There we are. So just keep continuing. I just want to officially welcome everybody to night 9 of our trauma series or virtual trauma rounds that we're running in conjunction with the Canadian Orthopaedic Trauma Society and MacOrtho Trauma. I just want to draw everybody's attention that this is going to be a 2-session week. So we have tonight's as well as one later on this week, where we'll be joined by the panel to discuss non-unions and malunions. But of course, tonight is the reason we're all here to talk about understanding the pelvis mass tabum fractures, and we're extremely lucky to have to be joined by Dr. Chip Rout, Milton Chip Rout from UT Houston. I'll briefly introduce here shortly, but just as a recap, we're doing this virtual series to connect with different networks, both locally and across the globe, to discuss different concepts in trauma. We're into the last stretch here of our 3-month series, where we'll be discussing pelvis mass tabum. It's part 1 of a 2-part session on pelvis mass tabum, and we'll be discussing some more concepts next week with Dr. Kelly Lefebvre as well as Dr. Pierre Guy. But tonight we're going to be focusing on a different level of understanding. We only get a chance to get in depth. As a review, there's 4 of us here at MacOrtho Trauma that do pelvis mass tabum fractures and reconstruction, and we deal with a catchment that's fairly large for Ontario. We on average would see about 1 to 2 pelvis mass tabum cases a week, and definitely we're a little bit busier prior to COVID. Last year we saw just under that average, just given to overall decreased volumes throughout the year, but it's definitely picking up as the summer months arrive. Myself and Dr. Dale Williams will be moderating tonight's session. I'm doing the introduction, and Dr. Williams will be introducing some cases. We both cover pelvis mass tabum. I was trained at Shock Trauma, and Dr. Williams trained at the Alfred in Australia, and we both get a chance to focus on some volume, but not nearly the volume that our keynote has dealt with over a lifetime of the groundbreaking techniques and teaching around pelvis mass tabum. Dr. Milton Chip Rout joins us all the way from Houston at UT Health. He's the Andrew R. Burgess Endowed Chair, and then has multiple leadership roles, both locally and abroad. He was previously at Harborview and joined the Houston group recently, or some time ago now, and it continues to be a leader in education through the OTA, AAOS, and the AO, and has multiple different positions that have allowed him to continue to educate orthopedic trauma surgeons around the world, and we're lucky to have him tonight. As mentioned, here's our intro, and I'm going to turn things over to Dale for a case to introduce some more concepts about pelvis mass tabums before we get into our keynote with Dr. Rout. So without any further ado, I will turn things over to Dr. Williams, and I'll just stop sharing here.
Great. Is that coming up? All right. All right. Thanks, Herm. Can you hear me all right?
Yep.
Yep. Okay, good. So pelvis mass tabulum. Thanks for organizing these, Herman. It's great. And Dr. Rout, much appreciated having you involved. So I'm just going to go through a quick case. What I'm going to do is there are going to be 2 questions there. I'm going to ask people just to commit to an answer via chat, either direct, private, or public. I promise not to make fun of you unless you're Dr. Habib, who's my current fellow. So 62-year-old male, works at the hospital, our hospital, of course, as a mechanical technician, and he's a healthy guy. He fell from a ladder while at work, about 8 feet, directly onto his left side, right on his GT, isolated hip injury, nothing crazy. So sort of the standard trauma x-ray that we get on a pelvis from a fall from height. I'm going to scan just, so there's the AP pelvis, a couple of Judet views. People just take a look at this. Another Judet. And then we have the CT, the Recon. So everybody have a look, and the next one I'm going to get you to commit to a diagnosis on this. So, and what we're going to get into is, what are we going to do with this? So this is, the bad of the bad of the acetabular fractures that we see. So I'm going to pause that. Go to the next slide. So classification, what is it? So everybody get on that chat and A, B, C, D, or E. So T-type, anterior column, associate both column, anterior column, posterior hemitransverse, or posterior column. So I want, yeah, especially our residents and fellows, commit to something. I'm not going to review it, just to make you put a number down, or a letter down, I guess is more accurate. Yeah, so pretty much everybody's so hitting CC. All right, so everybody seems to have committed. So it's an associated both column. I saw a couple of D's float by. It's a bit of a different associated both column. It doesn't tend to have the spur sign in this one because of the pattern of the fracture, but there is no segment of the acetabulum that's in continuity with this stable fragment connecting to the rest of the body. So that's the key on the associated both column, is this fragment's in continuity with the stable part of the body, whereas in the associated, or in the anterior column posterior hemitransverse, and then the associated both column, no aspect of the acetabulum is in continuity with the stable part of the body. So it's an ABC, fairly standard. So treatment. So what are we going to do? Anterior, so ilioinguinal or anterior interpelvic. Well, that's a controversial in and of itself. Maybe we'll talk about that later. Plate it. You want to do front and back and plate it, or extended iliofemoral if you so desire. Minimal incision, limited hardware, non-operative, or an acute total hip. So none of these answers are right or wrong, really. So commit to something. Yeah. All right, so it's a bit all over the place because treatment across the world where I've seen these fixed are all over the place. So I'm not actually going to give the right answer because I don't know if there is one, but the standard approach for a associated both column fracture is A, which is an anterior type approach, and the classic approach for this would be the ilioinguinal. Is that what I did? Well, we'll wait and see. So I started down that path, and in Oz, when I trained, we put an annealed plate on the brim and then let it bend as we fix the rest of it, get some stability. They sort of work upside down there because they're on the other side of the world, I think. That's not the standard AO way of fixing it. But we get in there and I started flooring it and I said, oh, that's not half bad. So I left it, for better or for worse. This guy's 62. So 6 months later, he's got this, he's back at work, full on, full range of motion, no pain. And then 7 years later, he comes back for some sort of abdominal pain, happens to get an abdo CT, which I grab a couple of cuts off of, and the guy's actually done very, very well. So this is not the standard treatment. But I thought it would prompt some discussion possibly on the idea of secondary congruence and it being your friend. This isn't exactly the right way to do secondary congruence, but it shows that it does heal, and especially in the associated both columns, you don't necessarily have to jump in and fix everything up. So I am going to put it back to everybody and maybe some comments on that. So not necessarily the treatment. As I said, classic treatment would be an ilioinguinal or an anterior interpelvic lateral window. That segmental bit on the back might have needed a posterior approach, but it's also a bit controversial. So I'm gonna, where are we at here? Back up. There we go. So Dr. Rout, I noticed you did the class, you said A, classic. Are you ilioinguinal, anterior interpelvic lateral window? What's your sort of approach on an ABC?
Well, I'll show you in a minute an example just like that and what we did. And I think people tend to do what they know how to do, whether it's right or wrong. And I just think if you know how to do things, you do things. And if you don't know how to do things, you mess around. And then if you don't know what to do, then you don't do anything at all. And so I really think people tend to, do what they know how to do. And I think the important thing is to know how to do a lot of things well. And that that's we'll get to that in a minute, but I have an example of that exact case, all done through an ilioinguinal, and it's one of the things that I talk about that I've learned.
Perfect. Yeah, that's great, because every course I go to, it's there's you're very accepting of both ways. I was at a Le course, and there was almost a fist fight over ilioinguinal versus AIP, and
well, I think if you look at the x-rays of people that do the AIP, you'll see that they tend to cover up their lines with the plates. And if you look at people that do ilioinguinals, they don't. And so you can actually see the work. So I think a lot of the work with the AIP just gets covered up by the custom plates that cover all the landmarks, and no one gets post-op CT scans. And the plate causes a ton of scatter if you use that implant. So that's become a really popular plate or an implant for a lot of people that just want to push it in, push everything over, put a bunch of screws in and hope it does okay. If you were that patient, that's probably not the approach that you want your surgeon to have, but it's become a very common approach. People say it's minimally invasive, it's less invasive, it's a better operation, but if you can't see the fracture and you can't clean the fracture and you don't reduce the fracture, then you're just relying on surgical secondary congruity. And sometimes surgical secondary congruity can work. It just depends on the dome coverage and the stability. Your patient had good dome coverage and wasn't bothered by having a very, significantly medialized hip. Some people really don't do very well with that at all. Your patient did well, many don't.
Yeah, he wasn't super. I think that's why there was no spur sign. He wasn't hugely medialized like the classic bad ones right into the middle, which I would have pushed out. It's funny, my supervisor in Australia, professor, says put enough what was his line? That guy put enough hardware in so he hid the fracture, which is exactly what you're saying.
Probably not a great way to go through life assessing your own results, is just covering them up. But a lot of people sweep up their house and just put it underneath the carpet and that's it.
That's good.
I don't think it's a great way for surgeons to go through their lives.
No. All right. Any other comments, Herm?
I was just going to say, I think that's an excellent segue to learn how to lift up that carpet and actually look to see what's underneath. So I'd love to hear Dr. Rout's talk, and maybe we can get some discussion going after.
Beauty. I'll mute myself.
Do you want me to share my screen now?
Yeah, that would be great. If you could start sharing your screen, I think you should be able to.
Are you able to see now?
Yep, that's coming through. Looks like your slide's coming through.
So this is our place. This is where I'm at. We're in the orange building is the Memorial Hermann Hospital, and the black tall building here in the front is where we have our offices. And then the University of Texas Medical School is just past the orange roof buildings. And this is the Texas Medical Center. The MD Anderson Cancer Institute is here, St. Luke's, a Methodist Hospital. Ben Taub is our next door neighbor as well, a level 1 trauma center. And I bring you greetings from all of my colleagues here. I work here for the last 8.5 years, and I work with this crew. Our fellows you see, Michelle Goslin and John Garlick and Travis Hughes and Jerry Chang are all leaving us here in a few months to go take their jobs, all go into academic jobs. And Josh Gary is leaving us to go to be the chief at USC in California. But I work with Andy Chu and Steve Warner, and y'all all know Jim Kellum there and Andy Burgess. They're our leaders, our Statler and Waldorf, if you will, then Tim Aker and John Munns, all extremely busy clinicians. We serve a population of about 7 million people and take care of mostly, not so much penetrating, but mostly blunt trauma. And I was asked to sort of comment about just sort of my career journey as far as pelvic and acetabular fractures goes. And so really, I saw recently on Twitter how people were saying how it started and how it's going. And so I just decided I'd probably go with the how it started, how it's going, and then mostly focus on what happened in the middle to make it go the way it goes. And that's probably something y'all would want to know too. I can just tell you that in retrospect, a career journey can be, it's difficult, especially if you choose to do something that's kind of hard. Some of the stuff we do, like the case you just show, is dangerous. But I've had I don't know any other physician that's had more fun than me. And I feel like I've had a very rewarding career just from the service. I would tell all the young surgeons that are trying to figure things out to try to find something that others don't want to do or can't do. That's a great way to have a nice niche career if you're doing something that others don't want to do. And I think y'all are all taught these days to try to protect yourself and don't do too much work. And I would just tell you that the thing that's helped me the most is just immersing myself in my work, and not so much just the work itself, but just the service. And that can be to the patient's clinical care, the research, advancing knowledge and education, all types of things. But the immersion really was the thing that sustained my career. Yesterday was probably the worst day I've ever had as a clinician for a variety of reasons. We just had a really, really dysfunctional day at a very functional system. But even then, you just pull back and realize that you're still having about the best day in the whole world. And I think it comes from the relationships of the people I get to work with, from the residents and the medical students and the fellows and the other faculty and the staff that work here. Also, I would tell you that if you have to leave the talk early, if you'll just use the golden rule for the rest of your life, whether it's treating other people or just your patients, you'll always win. And then work on your logic, common sense, and question everything. I have found that the thing that's helped me the most for peeling back the carpet is to question everything and assess my result. It's just what we were talking about. And then, I think you're going to find times when things get really hard and I would say that the world's lost a lot of its faith, and people have a tough time coping because they don't really have any faith to stand on. So I would say if you don't have a rock to stand on in a faith way, you probably ought to work on that. How it started for me was in Galveston, Texas in 1979. I started my freshman year of medical school at University of Texas Medical Branch. I went there because it was the oldest medical school in Texas, and it was where all the patients went. If you were an unfunded patient in the state of Texas in 1979, whether you were in El Paso, Amarillo, Abilene, no matter where you were pretty much getting shipped to Galveston if you had a complex injury, unless it was a tumor, and then you got stuck at MD Anderson in Houston. But if it was a non-cancerous problem, it got sent down to Galveston. So if you were a medical student or you wanted to be a medical student, that's where you wanted to go, is because that's where all the patients were. And this is what I found when I got down there as far as trauma care. This was really common. You don't see this much anymore, except maybe in some children, but we used to treat a lot of trauma when I was a medical student in spica casts. When I moved to Vanderbilt in 1983, the same thing was pretty much going on. Everything was pretty much closed management. This was one of my patients at the Nashville General Hospital when I was an intern in 1983. This CT scan was brand new. This technology of surface rendered images, you can see the quality of it. The patient was in the scanner for about an hour and a half. Just to get these images, and probably died of cancer within 3 months from the exposure to get this. But we've refined this a lot, but this is what we had. You see these malunions that occurred, and we passed out a lot of prescriptions for shoe lifts, crutches, and things to help people get along throughout their lives because of their pelvic malunions and non-unions. What we had in the 80s was we had a body of work that was pretty pathetic. We had the Scandinavian literature in a journal called Acta Orthopaedic, that there were several Scandinavian orthopedic surgeons that had contributed some clinical series and also some biomechanical series. And one of them was Per Slattis. And then Marvin Tile had published in a in a textbook, the work that he had learned from George Penal, his mentor. Dana Mears was in Pittsburgh talking about putting on these Eiffel Tower external fixators and doing double Cobra plates, which is something probably none of you have even heard of. Yoram Ben Menachem was an angiographer here at the University of Texas in Houston, and he was a huge proponent of doing angiography for essentially every pelvic fracture. And Dr. Burgess and Jeremy Young were at Baltimore and were working on their classification scheme. Ted Hansen was in Seattle being aggressive with fixation of fractures. And then Lettonell's book had just come out, and so we had that. But I was reading, my wife's a radiologist, and she had textbooks, that were this thick in 3 volumes. And I went on a vacation. We went together on a vacation. I was reading Marvin Tile's book, and it was, the first Marvin Tile book was about maybe 120 pages. And she kind of looked at me and said, "What are you reading about?" I said, "Well, yeah, pelvic fractures. I'm kind of interested." And she goes, "That sure is a thin book." And I think that's probably where my fire got lit, was to try to make the book thicker. In the 80s, there was a ton of disinterest and fear, very similar to today. In some situations, there's a lot of disinterest and fear taking care of these patients. The systems were disorganized. That if you wanted to do a fan and steel approach to plate a pubis, there were no plates and screws, and you'd have to get a urologist or maybe a general surgeon or even an OB-GYN doctor to come do the exposure for you. So most orthopedic surgeons had zero experience with any of these exposures. the pre-hospital care, the imaging. You know, if you wanted the details of an inlet, people would say tilt at 45 degrees. You say, well, you know, what am I even looking at? But it was 45 degrees. And the other one was 45 degrees for the outlet. And that was it. There was no detail to it. And of course, we didn't have much equipment. We did have a lot of urban legends. You know, I was taught that if I opened a pelvis fracture, it would either get infected or the patient would bleed to death. They had these hematomas that were dragons. They all did bad. You should never open them. And really the solution in those days was external fixation was the solution for everything. And acetabular fractures just sort of got the traction. This is a 1985 image from when I was a resident. You can see this is the combination of the Eiffel Tower on the pelvis as well as the spica cast. This is when you really don't know what to do, and so you do two things that aren't right. The care was very random. We didn't understand the value of reduction in its overall situation, and instability was essentially everything was stable because nobody wanted to operate on anything, and so we knew you had to operate on unstable fractures, but people were just saying it was stable no matter what. So I had a lot of patients that were in spica casts or else they were in traction for 4 to 8 weeks. This was femur fractures, pelvis fractures, acetabular fractures. And so you can imagine the pin site issues that we had, as well as if you roll the patient over. Almost all my patients had some version of this. You'd roll the patient over as best as you could, but if you sit on your rump for about 4 to 8 weeks waiting for your femur or your acetabulum or your pelvis to heal, this is sort of what I became an expert at during the course of my medical school and residency. We also had patients that looked like this. This lady started out with essentially non-displaced fractures throughout her ilium on both sides, and then her ramus fractures were both essentially non-displaced. And we just didn't understand instability. And so the patients had mal and non-unions. They had sitting and walking imbalances, deformity, and disability. It was all of everything that you could imagine to just be a horror story. And the acetabulum really didn't get any immunity to it. There was tons of closed treatment. And as you know, for unstable acetabular fractures, it just doesn't work. People started to operate. Electronell's book came out. And so people started to operate and the Recon plates came out. Some screws got a little bit longer than 50 millimeters. And then we started seeing x-rays like this, where people would take a swing at an acetabulum. And this was actually, the surgeon thought he had done a great job. You can see this patient's a pelvic ring and an acetabular injury. And they put the plate on distally on the lower segment of the acetabulum, but then up at the top, they just sort of rested it up on the top of the acetabulum. So it was some pretty bizarre stuff. People were obsessed with just classifying. I think clinicians really would sit around. A lot of people do the same thing now. They just sit around and classify fractures. And I think it's their way of understanding the knowledge that we have. But the imaging started to get better. We certainly were in arrears for that. The exposures, like I mentioned, we didn't have a lot of experience with. And then people started to do more, gear started to develop. We got Recon plate screws longer than 50. And then there started to be these things called clubs, like, are you in the Leternel club? Or sort of like y'all were talking about earlier with the fist fights at the course. You know, people were very, very protective of the knowledge that they had, and they wouldn't go beyond their yard. And we still see that a lot. People say, I know how to do this. And so that's what must be done. So I'm not really into clubs or territorial knowledge or things like that. I think you should know all that you need to know in order to do the job you'd want to do if you were that patient. And I think there's where the golden rule comes in. We also didn't know a whole bunch about the pelvic ring. You can see here, if you just showed this to 100 orthopedic surgeons, I think in 2021, people would say, well, why don't you just plate the symphysis? It would surely help a whole lot, but people just didn't know what to do. And they were putting on elaborate frames, the sacral bars. If you've never seen sacral bars, those are sacral bars, and those sacral bars are actually going through the spinal canal in the upper sacral segment. So this patient has had some real troubles. But again, this was just sort of what we were doing. And then if you did do open reduction posteriorly, Jim Kellum had shown us through a clinical series that you were going to have almost about a 40% wound complication rate. So essentially my career was driven by these things. And these things were, we were driven to try to understand percutaneous, and to understand percutaneous, we had to understand manipulative reductions, and understand manipulative reductions, we had to understand osteology, and understand osteology, we had to understand the imaging thereof. So this is what we were trying to avoid, is all of these problems that we had had with closed management and also these early attempts at open treatment. And basically it was failure awareness. Sadly, We, you'd think that there would at least be some little bastion of hope, and we couldn't even treat children closed. You'd see this is a 9-year-old that got run over when she was 5, and she was told, and her parents were told that she would remodel, and this is her remodeling, and she's, not a salamander's tail, and she's not a little adult, but as far as her pelvis is concerned, this is where she's at, and this could all be avoided. But again, the philosophy then was that children, just like adults, didn't need to be operated on. So what happened? That's how it was going. And I don't know about you, but I just was very unsettled with all of that. None of that struck me as something that I would want if I was a patient. So what happened is I moved to Vanderbilt, and I met this guy, Neil Green. He was my program director and the vice chairman there. I was his student in 1982 for a month. I fell in love with this guy. Essentially, I just had never met anyone quite like him. He was probably the hardest person I've ever worked for. His intensity was ridiculous. He was overly demanding, on the borderline of being boorish, but this guy made all of us that could sort of get through him a whole lot better. He was encyclopedic in his knowledge. He was a pediatric orthopedic surgeon, and he ignited an educational fire and just a motivation in me. And then the second thing that helped me so much was Mark Swinkowski was hired by Dan Spengler. Mark came in 1985, and essentially we went from being a closed management of everything to a trauma hospital. And so the trauma flipped. These are my 3 co-residents, and they all just hated Mark because Mark kept us up at night. And before Mark came, we didn't do anything at night. We didn't operate on essentially anything. And when he came, we were operating on open femurs. We were nailing everything. It was just, to me, it was like crack cocaine. To them, it was just horrible. So luckily, Mark liked me, and he took me to Harborview with him in 1988. I finished my residency, and he was leaving Vanderbilt. He stayed for about 3 years and went back. And so I went back with him, and we worked with this guy, Dr. Hansen. This is Sigvard T. Hansen, one of the icons of orthopedic traumatology for North America. Dr. Hansen gave me some great advice, and it's all. I would just say if you're a young or a young developing surgeon or physician or human, find people that you can emulate. And so Dr. Hansen had a lot of success being very aggressive surgically with femoral nailing. And one of the things he told me was that I probably ought to just try to do the same thing with the pelvis if we could figure it out. But he just, he didn't do that. But that was his motivation to me. The other thing that happened to me a whole lot is just to have a lot of relationships beyond just the profession, but to see people that I could emulate. So Keith Mayo was my partner when I first started. He stayed a year and then left in 1991. And then the pelvic job sort of fell into my lap. So I had a lot of serendipity. I had a guy that was a very good young pelvic surgeon leave in 91. And so I joined this faculty, and the Asian lady you see in the top left, she's Jane Inaba. She was my x-ray tech in the OR, and she taught me a ton. We learned a ton about imaging of the pelvis together. All of my partners did not like doing pelvic surgery, and so they let me take care of all of them. I thought it was a privilege at the time. The guy in the sweater vest there in the middle was our neurologist that ran our ER, and he was working 24/7, 365. And I thought it was incredible. He was really a powerful influence on me. And then we had a very active biomechanical lab. We were taxed from our salaries that funded the lab. So if you wanted to, use the lab, you pretty much had to. And so this guy in the black and white there with the glasses, that's Peter Simonian. He was an intern that came to my office when he was first starting his internship and asked me if I wanted to do some research. And we went to the biomechanics lab, and that's where we kind of flourished. So I dropped into serendipitously a very, very good situation. All of my partners let me take care of all the pelvic and acetabular trauma, got a concentrated exposure. It put upon me, I would say, incredible responsibility and things that I wasn't really prepared for. But the good news is nobody much was prepared for it. There was complex injuries and complex patients, and I had a 5-year clock. And if I didn't publish 12 papers, 6 as first author, I was going to get fired. And a lot of the attendings that come through Harborview, 5 and out, 5 and out, 5 and out. Dr. Hansen was one of the only ones that was able to make it back in those days because he did publish papers. So that was my goal, was to just make my promotion. The thing that helped me the most, I would also say, is I knew what was known, but I was realizing quickly that the problems that the patients had were really exceeding the knowledge base. And I could have easily just put an external fixer on this like most people had taught me to do, but it just didn't seem like the right thing to do. So I had this forced development as a result of the responsibility I had of taking care of the Pacific Northwest. I covered Alaska, Washington, Montana, and Idaho for pelvic and acetabular trauma for about 25 years. And so I learned quickly to listen to the patients. I knew what had been published and I knew what doctors were saying, but I just didn't think that the patients were getting what they were due. So we had to learn a lot about timing, exposure, decision-making, all these things were put upon me. But this, if you just look at this patient in 92, you can see this guy's got what looks to be an incomplete right SI joint, a complete symphysis pubis, and a complete left-sided sacroiliac joint injury. And if you presented this in 1992, or if you presented this in 2021 to a lot of people, they would say you need to open the SI joint, especially on the left. And Letournel said, do it from the back and go to the back first and all this stuff. And none of that made sense to me. I was born and raised on a farm and a ranch. And to me, it just made sense to sort of attack the front. And so this is a psychiatrist. I actually talked to him recently. And when I called him and told him I was showing him in a lecture, he started crying. It's not comfortable for me to be talking to someone I hadn't talked to in about 30 years, but he just started crying because he was aware of what this operation meant to him. And in 92, I took him to the operating room on a Saturday afternoon and opened his pelvis. He bled a lot until we clamped his symphysis. And then we realized that his posterior ring looked pretty good. And these were some of the first cannulated screws we had. The Recon plate was pretty brand new. And this was the guy that really sort of helped me. One of the first really, truly meaningful patients that transformed my entire thinking about what to do, because I was aware now that if we got a pretty good reduction in the front, the SI joints, even when they were complete, would close reduce, especially if you position the lag screw right. This was a patient from 91, a professional dance troupe who was going through Seattle, and she got in a car wreck and had a sacral fracture and ramus, some of the first ramus screws I did. And this woman had a plexopathy on the right. When we externally rotated her hemipelvis and screwed it, it resolved in a couple of days. This was her in the clinic visit about 8 days after surgery. So she went from having an unstable pelvis on a Friday night to the Tuesday next, whatever that is, almost not quite 2 weeks. This is how I found her. But again, she's a professional dancer. She travels all over the world doing all these fancy things and with this troupe. But I had never, ever, ever in my whole life seen someone like this showing off stretching and how comfortable she was. And I realized that we were on to something. So where we were was pretty bad, and where we wanted to go and was over here on the right. And these patients both have essentially the exact same fractures, treated just in different decades. And you can see the impact on just the reduction and fixation. Along the way, I had tons of failures. And one of the most important things for me was to not run away from the failures, but to really critically analyze each and every one, because I was doing things and I couldn't really get a lot of advice from people about what to do. Like when I would say, what do I do with a bent iliosacral screw? People would look at me like, yeah, you shouldn't have put that in. And the reason you shouldn't use that thing, they're really bad, you know? And so I was pretty much on my own. But you know, there was misery that we had company, and I learned about unstable ramus fractures and trying to just fix the back. And I learned about my spinal pelvic dissociation. This was the early 90s, and I could only find spinal pelvic dissociation in a single textbook that was written by a guy named John Connolly, and the solution for it was SpicaCast. So we continued to just grow our knowledge base based on the failures we were having with the different fixation constructs and trying to match where things went wrong, even though we thought they were right. And, you know, even with things like this, we were sort of under the impression if you took an injury like this and you fixed it all up and she's really big, so we didn't go after the symphysis, we just put her in a frame for about 7 weeks. She came back to clinic, we took her frame off in 7 weeks, and she started screaming in the room where we took the frame off, and this was her x-ray right after we took this x-ray. This was her at about a couple of weeks, you know, after surgery, and then this was her when we took the frame off. So this is when I realized that a lot of times things just don't work the way I've been taught that they work. Same with the iliosacral screws. There's, you know, if you don't do the screws right, those don't work out so well. And then the acetabulum, I think we've all learned the acetabulum is also can surely humble you quite quickly. So what happened was I learned a lot as a result of just a concentrated exposure with an incessant, nonstop fire hose of patients coming, and then the responsibility of taking care of all of them. Things I learned, a reduction is really important. The reduction gives you stability. I also learned that you should do the reduction as simplistically as possible and then do focal fixation. This helped me a whole lot, learning especially multiple levels, multiple screws at multiple levels, especially for really unstable injuries. Probably the best thing I learned was just the osseous fixation pathways, and this took a long time trying to figure out where these tubes of bone were within the pelvis. This once we sort of figured this out, then everything took off. But the osseous fixation pathways that are very, very common knowledge today, this was not common knowledge in the late 80s and early 90s, and took a lot of bumps and bruises to get to. I had a fellow named Sam Agnew. He went into practice at the University of Mississippi in Jackson. He came back after about 2 years there and said, you know, what are you doing with these things that you see down here on the bottom? And I didn't know what to do with them. And so one day we just sat in our library, went through 100 CT scans, and we sorted out dysmorphism. And at that time, there was nothing in the literature about dysmorphism. You couldn't read about it. They were called transitional vertebra. There was a little bit of spine literature, but really nothing that focused on fixation or imaging or radiology or osseous fixation pathways. So Sam and I sat there for a Friday and a Saturday looking at 100 CT scans and sort of sorted out what was this. And again, if we'd have had these surface rendered images, it would have made things a whole lot better, but we didn't have any surface rendered images back in those days. The other thing that helped me learn a lot was just the value of the reduction, but also the value of treating each instability site. And this was really controversial because people will still tell you today, a lot of people, and they'll put up their dukes about this as well, which makes me laugh a lot. But people will say ramus fractures are all stable; they don't need to be fixed. And that's fine. You don't have to fix them if you don't want to. And if you get one, I hope your surgeon fixes it for you, because they can be unstable. And that I don't understand what the conflict is, but it's just not that hard to put a screw in this osseous fixation pathway above the joint that supports it. It's just like, to me, it's just like nailing a femur, but to other people, it's like scratching their retina with a hot nail. But I don't understand the conflict about ramus instability and ramus fixation, but it's a real thing. But this was luckily something that I learned in the early 90s. I showed you the lady doing the splits that had the little 3-5 ramus screws. And I'm really, and my patients are grateful for it as well. And then again, we learned about multiple screws at multiple levels. This didn't really change. We got these long screws beyond 130 in 2006. So before 2006, the longest screw we had that was a 7.0 or a 6.5 screw was 130 millimeters. So you saw a lot of combo fixation left and right, trying to lock threads and things like that. We had to get a little creative. But once we got the ones that went to 180, then we were a little bit better off, because then we could sort of start doing the transsacrals other than S2. We used to do transsacral screws all the time at the second sacral segment, because it was usually 130 millimeters or so, and we could sort of get side to side. But in the upper sacral segment, we didn't have it until then. And then the kids, you know, one of the things I learned about the kids is they just don't all belong in a spica cast. And this patient, of course, was run over. She's 2 years old, and she's got really terrible soft tissue injuries that have to be dealt with by the plastic surgeons over a period of 2 weeks. So we learned that with you have unstable pelvic fractures, even in children, you can put them back together and then leave the hardware in until it's healed. And usually it heals pretty quick. Same with their elders. Probably the population that breaks my heart the most today is just the elders that are neglected with the U-shaped sacral fractures. People don't get the diagnosis until sometimes 4 to 6 weeks. They're suffering, they get caught Aquinas syndrome, they come in and they're incontinent and things like that, and all of it could just be avoided. So I've learned about, you know, taking care of the kids, the little ones, and I've learned about taking care of the older brittle ones, and the value of just, you know, stabilization of this area to give them the comfort for the mobility that they seek. And again, the long screws really changed everything for us with this. A similar example to the one you showed is what is this? You know, you showed left-sided injury of this, but this is an associated both column with focal comminution of the greater sciatic notch. And when I was learning, this was an absolute indication for an extended iliofemoral, and the combined sequential or, floppy lateral, front and back. Those were all things that I had done, but it just didn't work out very well. If you looked at the x-rays, it didn't look out very well. But, one of the things I learned is the value of a three-window ilioinguinal. That means iliac and then the middle vascular and then the AIP. I know y'all think the AIP is really new and it's something that's novel and new, but the AIP was introduced, at least to me, in 1988 by my attending, Dr. Mayo, as a component of the ilioinguinal. And so I just thought that was a window that was done. There was a guy named Eero Hirvensalo that I met in the early 90s in Sweden at a meeting, and then I backtracked in Eero. He had described this in clinical orthopedics and related research a little bit earlier than that. And then I think y'all know Brett Ballhoffner. He also had described this approach. So I know it seems like it's new, but if you go back and read old literature, Eero described it in the early 90s. But I was luckily taught this, and I think one of the best things I learned was just this ability to do a 3 to 4 window ilioinguinal, and then the ability to work within this area to reduce the fracture and put things back together to where the x-rays look symmetrical. I never had a special fracture table or any type of outriggers or traction tables or things like that. I just had a flat top table. And then if I needed a little traction, I'd pull on it. But what I realized that these are all unstable acute fractures. I got them all fresh. And, if you clean them and clamp them, they go back where they came from. I also learned the value of a prone Coker Langenbeck. I'd never been taught a prone Coker Langenbeck. I'd always just been taught lateral. And this was really terrible for doing any type of medially unstable fracture, like a transverse posterior wall or a transverse fracture. And the prone this 1989, I would say, changed my entire practice. The other thing is I learned from Bob Winquist the value of just taking out the caudal portion of the minimus just below the superior gluteal neurovascular bundle. I learned not to be afraid of it and not to look at it, but to actually look at it. I learned the value of doing a sciatic neuroplasty to free the nerve so it doesn't get hurt. And just learning to deal with things rather than to ignore them and hope that they were better was huge lessons for me. I mentioned the external femoral. I was taught this. I was told I should do this. I've done probably 12 in my entire career. But one of the things I had an attending who was big on the external femoral. And when I was a fellow, I saw patients like this. And I don't know about you, but you can give me just about any acetabular fracture. And I don't care what malunion I get, I don't want this, because I think with whatever I got, there's always some type of solution. When I have this, there's not much of a solution. So I'm not a big fan of extendulofemoral, but I think people still do it, and God bless you. This is the x-ray I showed earlier, just with the segmental notch. And I think, again, if you know how to do the different things, if you know how to do all 3 windows and clean and clamp the fracture, you can make a very pretty result. You can have primary congruence. You don't have to rely on secondary, and you can provide stability so that the patient can go back to doing the things that they do. I'd say 95% of the acetabular fractures that I take care of, these are about the only tools I use. 2 medium tenaculums, one's modified, one's not. This gooseneck shaped clamp that you see there in the second from the left on the bottom row that has a variety of applications, a spike pusher and a Chance pin. So based on all this stuff, my whole thought process just changed from an acetabular perspective to where, I had to learn about all of these different aspects of not doing traction, but I learned to name the fragments, the surface rendered volume. I mean, the surface rendered CT scans really helped me a lot. I would have given a finger to have had these in the early 90s. These are practice changers, knowledge changers, and I can encourage the young surgeons strongly enough to spend as much time as you can learning osteology and its correlation radiographically. I learned to plan, I would say, excessively. And I learned to use the opposite side for planning just as much as the injured side. I planned everything from where my retractors went to how I was going to see the surfaces to how I was going to retract the vessels, all these things. So my plans were elaborate, and then the surgeries were almost always uneventful. And then as far as clamp applications and trying to get the clamps on and getting everything, that really was a huge learning as well. I was taught to use single long plates. This is a patient I did in 92. This is her 9-year follow-up. She came back to see me because she had low back pain. You could see we did her before we even had cannulated screws. That's a fully threaded screw. We used to use 6.5 screws for the sacral fracture that she had. but I was taught you had to use these really long plates to sort of put everything back together, and that was your goal, was to put this long plate. I found these very cumbersome, difficult to contour, and a joke. Basically, it just didn't make any sense to me. Being on a farm, if someone would have given me some tool that was cumbersome, difficult to work with, I'd have thrown it as far as I could and found something simpler. And one of the things I found that's simpler is just focal plating. I think people know this now, but in the early 90s, this was pretty revolutionary for me, was just to understand that really all I had to do was put plates like my thumbs. Wherever I put my thumbs, if I was pushing it back together, that's pretty much where the plates needed to be. So I learned about just focal plating and balance fixation and targeted fixation, so we could plan and understand how we're going to see it, clean it, reduce it, clamp it, and still get the implant on. The new implants that y'all have that are these bigger orthogonal plates that sort of go in through the AIP, they're really difficult to get into the wound if you've got a clamp on the fracture. You can always try to hold everything with a lag screw, but the reality, then you're going to put the plate on top of your lag screws. And so I'm just not much of a fan. I like focal plates that are specific for the fragments, just like this, sort of a poor man's orthogonal plate. And you get nice. The other reason I like it so much is you can really make the hips very, very good to where they can stay away from the arthroplasty doctors. I also learned to trust the patients a lot over the doctors. I was told not to do elders. I was told their bone quality was bad. They were almost always unhealthy. But this is an 86-year-old guy that rides his bike 100 miles a week or more. He's a very active guy. And I realized he crashed his bike and he's got this both column, but I can put this back together in about 3.5 hours. And this is his 3-year result. He's still riding his bike. Now he's 3 years older and he's still riding every day. So I really learned to listen to the patients and not so much to the doctors. I'll also tell you the thing that's really kept me going was the thing that Neil Green told me would keep me going. I really wanted to go back to my hometown and just be a general orthopedic surgeon. He refused to allow me to do that and just told me that I would at least have to go teach for a couple of years and just try it. And so I became an educational addict. I think it's really helped push me along. It's subjected me to incredible scrutiny. It allows me the opportunity to share, to listen, and to hear, and to learn what other people are thinking. Sometimes it's great stuff, sometimes it's foolishness. And then it gave me an avenue to just try to be as clear as I could and keep things as simple as I could. I love teaching, as maybe you know this, but I'll teach anyone that wants to learn anywhere, anytime, for as long as they'll hang with me. And I really like the most is just working one-on-one in between cases with either the residents or the fellows or the students, and identifying what they don't know. You said, well, you're teaching them on the wrong side of the table. They were right next to me for about an hour while we were waiting on the patient. And then the patient is wheeling in the room right behind me, so they're moving around. But I like drawing and just identifying what their holes are and the learner's holes, and then just being specific and giving them some visual. We can give them the sheet when we get through and they can take it home with them. I also like, detailed teaching and techniques. It's always a lot of fun to teach. Here you can see some of the AO surgeons learning MEO techniques. And then my favorite is just sit around and go over cases. And this is from medical student to junior resident to visiting surgeon to fellow, and just make sure that each and everybody sort of walks away with something that's relevant to them. And you can't teach everybody at 602. You've got to teach some at 101, some at 201. And you've got to adjust for the person, but I'm addicted to this. And then the research really drove us to be our best. Everything that we learned and everything we got to do clinically, we tested in the lab first. And this really allowed us to know that what we were doing and what was seemingly very aggressive and crazy was absolutely biomechanically sound, and it could be done very safely. So I can't be more grateful to this intern who came into my office and said, hi, do you want to do some research? I'm kind of interested in research. That guy published 56 papers in 5 years during his residency, and about 30 of them were first author papers. So he had an incredible engine that was very motivated, but I sort of got in his slipstream and just sort of followed him around, and he helped me a whole lot as one of our residents. And then I'll just tell you, probably the thing that's helped me the most is just to not forget my family. So you have to have somebody to help you if you're going to be an educational addict and a fixation addict and love to do research. I coached all my kids, not soccer, but I coached their basketball and baseball teams until they got to the point, once they get about 13, their baseball skills and knowledge, it goes beyond me. So I took them from around 6 till 13. And then I kind of just became a fan after that. But I enjoyed coaching. Sometimes that meant I had to operate at 8 o'clock at night instead of 3 o'clock in the afternoon. But I'd punch out, go do a game, and then come back and do an operation sometimes late at night, or do my research late at night. And then I think you have to take really good care of your crew. You know, this is part of our OR crew on the lower left. I took them to the Astros game. Dr. Aker has a big party. We have a very, very social department with our residents, our fellows, our x-ray techs, everybody. It's just it's an all skate, and we have a good time. And I think that's important. And then finally, I'll just say that one of the things I've learned is you tend to your own self to the amount that you need to be tended to. The last couple of years, I got a lung cancer a couple of years ago, a metastatic adenocarcinoma that sort of caught me by surprise, but I tried to stay fit and very functional my whole life, you know, even if it meant a workout at 11 p.m. or if it meant a stationary bike in between cases, whatever it took. I had sort of a gym in my office. So, you know, kind of had slow operating room in Seattle. So I got fit in Seattle just in between operations, but you have to have some protected time to keep yourself fit. And you've also got to use whatever time you have to reassess what you're doing. If you don't reassess your results and really go critical at not just your successes, but your failures, you can't progress. And you've got to either validate what you're doing or get away from what you're doing poorly. That just means that you're nourishing your soul and nourishing your brain. And then I'll also tell you, so many people are burning out today, and I've never even been close to burnout, but I will tell you, I get tired. I think everybody gets tired. One of our junior residents, I literally got his teeth knocked in. I think he had 34 consults on call, and 17 of them were operative. And I was overwhelmed just looking at what he had done. And I said, "Are you okay?" And he said, "I may cry, but I ain't going to crack." I think that's a really good philosophy. I actually had him repeat it because I'd never heard anybody say that before. And he just said, "I may cry, but I ain't going to crack." And I think people tend to crack. And what you have to do is either cry if that makes you feel better, but rest. One of the things that people don't do is they don't rest when they get fatigued. And Vince Lombardi, a very famous NFL coach, said, "Fatigue makes cowards of us all." And I just think that you have to keep yourself fit and keep yourself rested. Find your faith. You'll find that there's not a lot of atheists in a foxhole. And when the adenocarcinoma shows up in your chest x-ray that you shoot because you've been coughing for a while, you'll be happy if you've got a foundation of faith to stand on. So I appreciate y'all having me. I could talk to you for hours, but I'm going to stop. And I'm happy to answer questions or do anything that y'all would like me to do that would make things better for you. But I'll stop talking now.
Well, I just, on behalf of everyone here in attendance, thank you so much, Dr. Rout. That was incredible. It's eye-opening to hear your journey and inspiring to hear everything you've gone through and all the changes that, we benefit from seeing all the hard work you and the team behind you put in. I would I'm going to encourage everybody to kind of put some questions into the chat, or honestly, just put up your hand. We'll look for the hands and speak up, unmute your mic. I think the question that kind of came to mind as you were going through all of that and all the different people who inspired you to change, and it was listening to the patients that I think stood out the most to me. And as you kind of saw where you had been or where things had been when you came in, what would you say as you've gone through the last your career, really, like what have patients really wanted to improve in terms of, is it, and I know it's different per patient, but was it the pain they would have, the avoidance of complications, wanting to get up and walk sooner? Like, what was, in terms of pelvic acetabulum, what was the biggest complaint of where things were and what they wanted to achieve?
Well, I think instability, the trick is that instability sorts itself out really quickly, and people will tell you if they're unstable. So the majority of people know when they have an unstable ring because they can't roll, they can't move, they can't talk, they can't sit up. They don't want to do anything. They don't want you to touch them. They don't want anything to do with anybody. And that's always a great clue when you see a bunch of fractures that don't look very displaced, or, you know, it looks like, well, that doesn't look very displaced. Then you examine them and they collapse completely. And so I would say the thing that was most motivating for me was just the suffering I saw from the treatments. You know, the disease was worse enough. You know, the acetabular pelvic fracture is bad enough. But then you see spica cast and prolonged traction, or you see these things that people are doing with the Eiffel Tower X fixes or whatever it is, and you just realize that it's just something you wouldn't want to have. You'd rather have medullary fixation. You'd rather have stable fixation. You'd rather have everything fixed and reduced and stabilized to where you don't have deformity, you don't have disability, and your soft tissues can heal normally, your bones can heal. The x-ray, you're not ashamed to show the patient the x-ray in the clinic. So all of these things contributed to trying to just make things better. And then, you know, it was really easy because the imaging was getting better in the operating room. C-arms were coming in, the CT scans were doing better. My wife was the head of CT, mammo and ultrasound at Harborview for about 8 years. And so, you know, I was getting post-op CTs on all of my patients, which was extremely controversial in that day. But there was no way I was going to learn this and know where those screws were if I didn't get post-op CT scans. I could shove them in and say, well, I hope that's okay. And they're moving their toes, so it must be really good. But then you look at the CT scan and say, oh my God, you know, what the hell is that? And then you say, well, oh, the ala slopes. Oh, and I mean, it took me till patient 26 before I realized the ala sloped, and it wasn't just a cube. And there, yeah, it's not, you say, well, everybody knows that. Nobody knew that. And it wasn't written down. And you didn't realize until Jane and I made a model, and we put the screw out the top of the ala and then shot an inlet and shot an outlet, and it was superimposed. And it's like, oh my God, you know, this is an ellipse. So then everything just sort of built from that. So it was an all skate, and everybody I was working with and was pushing it. Most of my partners were all for it, and then I was taking all the pelvic call for them, and so, you know, that was good for them. You know, it was a win all around. That was good.
I have to make a comment that fortuitous circumstances, yes, but also bravery. I have to commend you on that, because we're so paranoid about litigious patients and sticking our neck. Always being told if you stick your neck out, you get your head cut off. And
yeah, I disagree. I don't agree with that. I've never been that way, and
that's good.
I never even thought about that thing. I've had one patient sue the University of Washington in 1991. Is when I did an arthroscopy, and that's the only legal situation I've ever been in. And I'll tell you, your analogy is really good though, and I think. Every time you do something that's more aggressive than the last thing you did, it's like taking a step on the ice. You know, you don't know where the ice is going to crack, and you never know where your limit is until you just get to the edge of the ice, and you've got to be sensitive. You've got to hear it crack, and you've got to know that and then you've got to pull back a little bit. It's like people never get to the edge of their ledge because they don't get on the ledge. But it was pretty easy to get on the ledge with these patients because what was happening to them, I just didn't think was a good thing. And I thought what Dr. Hansen had done with the femur could be very much done to the pelvis. And I could hear Dr. Tile talking about some of the things they were doing, and Trevor Hearn was his bioengineer, and it just all sort of spoke to me, and we just sort of picked it up and went. And then I worked in a in the early 90s, you know, the place was everybody was pushing each other to, you know, Steve was working out calcaneus, Dr. Benershka was working out calcaneus fractures. Dr. Hansen had pushed the femur, and I mean, Mark was doing osteomyelitis with the laser Doppler flowmetry, and everybody kind of had their deal. So, I think the whole Northwest relied upon us to sort of keep things improving. So it was what we were supposed to do. It was just the mentality. So the bravery was environmental, but I really did feel like I was pretty much way out on a limb by myself a lot of the times. I'll tell you, or room 3 down in the basement of Harborview on a Friday afternoon at 3 o'clock is a pretty lonely place to be.
When you're the only guy for 5 states.
Yeah, everybody's really interested. I mean, everybody's very interested, but the problem is interest and solutions don't always go together. And so the people that are with you, that are helping you, and they're the fellows and everybody's interested, but you need solutions. And the problem was I just didn't have solutions. So that made it hard.
I think
Good. I think that's a great lesson to take from this.
Yeah.
I was going to say that shows bravery, not just on the medical legal or pushing those boundaries, but the pushing the boundaries of dogma. And it was challenging everything that had been taught to you beforehand to say, hey, that's not right. And you think there's a better solution. So I think, that I think is incredibly inspirational.
The first series we showed at the OTA, we showed this, percutaneous, and I'm going to tell you, I'm glad there wasn't a tomato stand next door, because there were like 20 people in line. It was like, what are you doing? We don't do this. This is not necessary. It was an assault. It was an academic assault.
And
I'll never forget it.
Well, and that's whenever you change or shift the sands to that degree, you're going to confront that kind of thing. And now I think as people understand what those principles mean to patients, the stability, their function, and then the overall improvement we see in their outcomes, it's hard to believe people didn't see that from the get-go. So thank you.
Well, I didn't care what the doctors were saying at the meetings at all. I couldn't care less, because I knew what the patients were saying in the ward after the surgeries and what they had said, in spicas and traction. And I knew what they were saying in the ER, and then I knew what they were saying immediately post-op. And so I didn't need a study to show me that the pain was better. I didn't need any of these things. They say, what was your pain before surgery? 10. What is it now? 2. That's all I need. I'm good. Let's get up.
Well, I think that's fantastic. And I just want to just throw one last request to see if there's any questions from the group. But I think, we've tried to incorporate some of the things we've heard over the last, not just tonight's session, but over the last few 2.5 months. We've talked about different concepts in fracture. And one of the first talks we had was about value and how to discover and look for value, and listening to the patients was a fundamental concept in that, and listening to them say when they're doing better after something you've done, that's enough to keep going. So if there's no other final parting thoughts or questions, I do want to respect everybody's time more. Most importantly, Dr. Rout, who's definitely carved out some good time for us, valuable time given how busy he is, and lots of patients to get back to. So thank you so much. Thank you, Dr. Williams, Dale, my colleague, to help present the case and moderate, and to the audience that turned out. Looking forward to seeing everybody for subsequent sessions and wrapping up some discussions. So thanks again, everyone.
Thank you. Bye-bye.
Thanks, Dr. Rout.
Bye now.